As you all are aware, we have changed the definition now following this Berlin definition of ARDS, where the timing should be an acute onset within 7 days after a non-clinical insult or a new worsening respiratory symptoms. And the edema should not be fully explained by cardiac failure or fluid overload, subjective assessment by echo. So echo should not show the cardiac failure features. And based on the oxygenation, last time we have discussed, based on the PF ratio, we can divide into mild, moderate, and severe. And with the PEEP of equal to or more than 5, last time someone has asked. So PEEP this is a PEEP criteria. And the chest imaging should be bilateral opacities with more than 3 or 4 quadrants, not explained by other shadows. So this is the definition of ARDS. I'm not going into the too much the theory part of ARDS. And the physiological task in managing any ventilation, last time I've already told, carbon dioxide elimination, oxygenation, and assistance of respiratory muscles. But in ARDS, our main aim of ventilation is to maintain oxygenation by keeping these closed alveoli open and recruiting more and more closed alveoli. So that will be the our aim. And this was also discussed last time. Depending on the severity, like from mild to moderate ARDS, for all group we go with a low tidal volume of around 6 ml. The PEEP in the mild we use a very low PEEP, then a moderate PEEP of around 8 to 10, and severe ARDS we go with a high PEEP of 11 to 15, and more than 15 there is no evidence. Initially with mild ARDS we can try NIV or high flow nasal cannula, but with a severe ARDS we will have to prone ventilate, recruitment maneuver sometimes, and neuromuscular blockers. And severe ARDS, when the PF ratios are less than 50, we go with the ECMO. And this was also discussed. We have, like when we are pushing the air inside, there will be a resistance offered. Then the alveoli will be recoiling, and the volume will be pushed back. And the volume placed in a closed space. When you place a volume into the closed space, it will increase the pressure. And in ARDS, we will be having a normal alveoli and a alveoli which are stiff. And the normal alveoli will not require higher pressure, but the stiff alveoli to open up will require more pressure. But when you apply the pressure, so the pressure will definitely move on to the area of less resistance. So there can be a chance of overinflation, and the volume change for a change in pressure, we call it as a compliance. So this term and concept should be very, very clear to understand COVID ventilation also. And what pressure we have to monitor, we have already told, we have PEEP, we were discussing in COPD, PEEP plateau we have, and we have having driving pressures as well. And in mechanical ventilation in ARDS, you should understand there are like in the ARDS length, we can have a normal length with like a reduced length volume where we have to use low tidal volume to protect that. So we will have to hypoventilate, and there will be carbon dioxide retention. The next part, we have to prevent the cyclical stretching by PEEP or prone by recruiting. And the consolidated length, we will have to require high pressure to open up, either by using recruitment maneuver or by using moderately high PEEP. And with the life-threatening refractory hypoxemia, we will have to sometimes open up these airways. So what is this recruitability? We have told last time, just refreshing those things. So when we put the patient on, say, volume control mode with 400 ml and 8 PEEP. So this is how it will be. It will be just opening up some of the alveoli. So now I'm increasing the PEEP. So herein, when there are responders, like where with the higher PEEP, more alveoli will get recruited. So these group of persons are called responders, and the whole aim of ARDS ventilation is how much PEEP to be provided to open up these recruitable lung units. But at the same time, like if you are applying more pressure, there is a chance that these sometimes the small alveoli, the normal alveoli can burst, and it will not recruit more alveoli, and these group of persons are called non-responders. So we should try to understand in ARDS ventilation who are the responders and what is the optimal PEEP, and what are the other measures by which you can improve the oxygenation status. Okay, so here again you can see if you put an inspiratory hold, like in responders, you can see here the plateau pressure was 30, driving pressure was 22. So here you can see the plateau pressure was decreasing, driving pressure is decreasing. At the same time, the compliance is improving. So this is how you look. Like if it is a responder, the driving pressure will drop and the compliance will improve. But if it is a non-responder, with a PEEP increment, you can see the driving pressure will be shooting up and the compliance will be dropping down. Okay, so this is how you should approach an ARDS patient. And again, we have to use low tidal volume. We have to aim for a low plateau pressure less than 30, high PEEP to open up the lung, low driving pressures less than 15, low mechanical power, and reduce cumulative injurious strain. These last two, like because of lack of time, we are not making it complicated. And when you are applying the pressure, obviously the pressure will be utilized to distend the alveoli, and again it will be also used to move the chest wall. Okay, so when the chest wall is stiff, obviously you will have to use more pressure to expand the chest, and the pressure may be exerted to expand the chest, and the pressure, the alveoli are exposed. This what pressure here it is exposed is equivalent to the alveolar pressure minus pressure imposed by the chest wall. So this will be the our like the pleural pressure, or otherwise it is called as a transpulmonary. Sorry, otherwise it is called the from that pleural pressure we can actually derive what is transpulmonary pressure. So that will be the actual driving force. Okay, so the transpulmonary pressure is a plateau pressure minus pleural pressure, and the lung protective strategy in ARDS will be to keep plateau pressure less than 30, low tidal volume ventilation based on predicted body weight formula, which we have discussed last time. Male it is 50 plus 2.3 into 18 inches minus 60. In females it is 45.5 plus 2.3 into 18 inches minus 60. So which with such low tidal volume deliberate hypoventilation, what change will be there? There will be carbon dioxide retention. Then again there can be other issues like the inspiratory pressure. You can see when you are applying the pressure, the driving pressure can change and the plateau pressure can also change. The plateau pressure can be determined by an inspiratory hold, which we have already discussed last time. And the maximum pressure exerted is the peak inspiratory pressure, which we have seen already during COPD ventilation. And with an inspiratory pause, we can see the plateau pressure, and the change between the plateau and the PEEP is called as a driving pressure. So this is a high PEEP resistance, and again the concept should be very clear. Here in this one patient, I am applying a PEEP of 5, and the total pressure is plateau pressure is 25. So the driving pressure in this patient is 20. So the same patient I am increasing the PEEP to 10. So the plateau pressure is now 30, but the driving pressure here is 20. Okay, so here the more lungs are recruited, but the driving pressure remains same. Okay, if sometimes if the recruitment is better, the driving pressure may dip down. So by increasing the PEEP along with the compliance everything, now we give more concentration on driving pressures. So you don't have to worry much about other pressures. Again, from 15 we are increasing. Now the plateau pressure is 35, but still the driving pressure is 20. Okay, our target for driving pressure is 15. I have already told, but this is just to make the concept very clear. With increasing PEEP and increasing plateau, you can have a constant driving pressure possible. Okay, so that concept should be clear. And how to see the driving pressure in a pressure control mode. So whatever pressure control over PEEP you are keeping, plus the PEEP. This is a total pressure control above the PEEP. So the plateau pressure will be the total pressure. So the plateau pressure here it will be 12 plus 18 will be 30. And what will be the driving pressure? The pressure above the PEEP. So this will be the driving pressure. So here in a pressure control mode, you know what is the driving pressure, and you know what is the plateau driving pressure and the plateau pressure. So here again you can see the tidal volume divided by the driving pressure. So the compliance, the static compliance will be 25 centimeters of water. This is how we come to the calculation or the derivation of static compliance. So whereas in volume control mode, when we are putting a 450 ml tidal volume with a PEEP of 12, we will have to put the patient on an inspiratory hold to see what is the plateau pressure. Here you don't have to do that. Even without inspiratory hold itself, you will get to know what is the plateau pressure, the driving pressure, etc. This we have discussed last time, but just once again refreshing. The 15, less than 15 driving pressure by this amateur trial has showed a decrease in mortality. That is why we are trying to ventilate an ARDS patient with a driving pressure of less than 15. The assessment of recruitment can be done in different ways, either by the CT scan, which is a gold standard, impedance tomography, a PV tools, an esophageal balloon looking at pleural pressures, or like a best oxygenation or a best compliance PEEP. So today's class we will be discussing on the best compliance PEEP method, and the other option is looking at stress index, which we will not be discussing. There are other options like FRC, looking at best FRC, etc. The simplest way for PEEP titration is go with an ARDS-net PEEP table. There is a high PEEP table and a low PEEP table. The majority of the time we use with this low PEEP table, which we have discussed. So what is the recruitability? Now we have already told. So one patient from 8 to 12, when we are applying the PEEP, more alveoli will be recruited in a recruitable lung. But if it is a non-recruitable lung, even the baby lung will rupture, and obviously these patients will be having the worsening compliance. Here you can see the recruiters, the plateau pressures and compliance will be improving, but here it will be worsening. So here in this group of persons, from 8 PEEP, when we are increased to 12 PEEP, you can see the static compliance is increased from 19 to 25, and the driving pressure has dropped from 22 to 16. So now we want to know whether the 12 PEEP is enough or whether we want to give more PEEP. So I've increased from 12 to 14. So here when I'm using a 14 PEEP, now the plateau pressures are 30, but the driving pressure from 16 to 16, it has gone up to 18, and the compliance is decreasing. So this is how you look at best compliance and best compliance. So from 18, the compliance is increased to 25 when you're increasing PEEP from 8 to 12. From 12 to 14, when you are increasing, you can see the plateau, the driving pressure, and the compliance is decreasing and driving pressure is going high. That means the optimal PEEP for this patient is 12 centimeters of water. The recruitment to do, the patient should be passive, deeply sedated. The paralysis is not always necessary. Patient should be hemodynamically stable, and the cuff should be slightly more inflated. We have discussed this also last time. 3 types of recruitment. You can give it a sustained inflation, or like an incremental PEEP. Gradually you increase the PEEP to like reaching up to 40, hold it for 30 to 40 seconds, then gradually titrate down. Or simple terms, we can control ventilate with 20 PEEP and 20 centimeters of pressure above the PEEP. So total 40 centimeter for 40 seconds. So this method we will be discussing in detail. Okay. So these are the once like you recruit, you should know what is the optimal PEEP and how to titrate. So these were the points which we were discussing last time. So now coming to the ARDS ventilator settings once again. So how we will start? Any patient when they are hypoxic, you start the ventilation with 100%. But at the same time, you should be aware, you should try to reduce it to the non-toxic level of oxygen, which is 60%. So even when with the 100% or a 80%, your patient is saturating more than 90%, that patient is very, very sick. And somehow with all ventilatory modification, you should try to reduce the FiO2 to 60%. And the tidal volume, always you have to try to keep it around 4 to 6 ml. And the plateau pressure, try to keep it less than 30, and driving pressure less than 25. The PEEP setting I have already told, which we will discuss in detail. So PEEP should be set in such a way that we should try to reduce the driving pressure to less than 15, or a plateau pressure somewhere around 28 to 30. and you have to adjust the pH to keep more than 7.25. How we can do that? You increase the respiratory rate. And PCO2, it is always not necessary you have to keep it less than 50. You don't have to worry much about the PCO2 values. And the tidal volume, depending on different groups, like in majority of the groups, you can keep it somewhere around 4 to 6 ml. And PEEP in mild group, we keep it at around 5 to 8, moderate 8 to 12, and severe 12 to 16. So these things how we are going to ventilate the patient. So I have a patient with severe ARDS. Okay. So now, like I ventilated, I want to recruit the patient. So what I am going to do? See, this patient is holding on with a 50% FiO2. So I kept the FiO2 at 50 itself. I kept the pressure control, and the control I kept at 20. PEEP at 20, and it is a assist pressure control or PC or an assist pressure control mode. And then like I am ventilating it for 40 seconds. So 40 pressure for 40 seconds. To 40 seconds. So after we do, this is the process. So now we have already recruited. The saturation is improving. So what to do now? So now you know the compliance here is 20, like tidal volume by driving pressure. So here again the plateau pressure, as you know, the plateau pressure is 40, and the driving pressure, the difference is 20. So now we know that driving pressure is high, the plateau pressure is also high. We are trying to open up maximum alveoli. Now what we can do? So now the driving pressure we want is 15. So what you have to do? The pressure control you reduce to 15. So now your driving pressure will be 15. The PEEP, you want to see what is the optimal PEEP. So once the lungs are completely open up, you can try something like a downward titration of PEEP. So now from 20, I have reduced my PEEP to 16. So what should I know? Whether the 20 PEEP is better or 16 PEEP is better. How will I know? I just put an inspired hold. I just read the tube. Now see the plateau pressures are coming down, and see compliance. From the 20, compliance has improved to 24. Okay. At the same time, you have to see whether you are getting an adequate tidal volume also, because this is in the pressure control. Okay. Now I've reduced the PEEP to 16. Now I'm getting a compliance of 24. Still, I don't know whether this is the optimal setting, because the compliance is 24. Sometimes this PEEP may not be required. So I will again reduce the PEEP to 2 again. So now in the same pressure control, same FiO2, I have reduced from 16 to 14. Now the compliance is again slightly improving. So how will you know? The driving pressure is constant here because you are ventilating with a pressure control. So whatever pressure control you are keeping above PEEP will be the driving pressure. So you have complete control of driving pressure here. So the driving pressure here again 15, but the compliance is improving here, and the plateau pressures are also improving here. Obviously that will be reflected by improving tidal volume. Last time someone was asking how much time you have to wait between like the changes. Again, there is nothing like a fixed time. You can give it somewhere around 5 to 10 minutes and wait what changes is happening. So now I don't know whether the 14 is adequate, so I am changing to 12. So when I am changing the P from 14 to 12, again you can see my plateau pressure is dipping, the compliance is improving, and obviously the tidal volume also has to improve. Okay. So now with the reduction in PEEP also, I am having an improvement in compliance. So the patient does not require 20, 16 or 14 PEEP. With the 12 PEEP, the patient is having better compliance than the previous higher values. So I have to again down titrate and see. Now again with the same setting, I have reduced the PEEP to 10. I have measured the compliance. So here you see now the compliance is dipping. That means what does it indicate? So the patient best PEEP here is based on the compliance, it is 12. I've already told there are many methods for PEEP titration. This is a one simple bedside method by which you can titrate PEEP for ARDS. Okay. This is I've already told, this is a 3 sessions only. We have so many topics to cover. So at least this basic concept, if you understand, you can ventilate a severe ARDS patient. So I think that concept is very, very clear. This is called the decremental titration of PEEP. So you recruit with a high PEEP, gradually reduce the PEEP values and see at what PEEP the patient is having a best compliance. Now you are in a pressure controlled decremental PEEP titration. Now we again go with like you can see, I have again recruited the patient, FiO2 50, pressure control, PEEP 20. Now I am seeing the patient with a volume control mode. How to titrate the PEEP in a volume control mode. The majority of the trials are done in a volume control mode. So here I have calculated, and with the predicted body weight, I have calculated around 6 ml, and it is coming 350 ml. So from 16 I have reduced the PEEP to, sorry, 20 I have reduced the PEEP to 16. I have put it in an inspiratory hold, and now my driving pressure is almost same. The compliance is 24, the plateau is 36. So here two things you cannot accept now. The driving pressure is high, more than 15. The plateau pressure is also more than 30. So you cannot accept this much secretion, this much settings. So now again you try to reduce these values by reducing the PEEP. So from 16 you are again reduce the PEEP to 15. 14 you keep the tidal volume constant and see what is happening to the driving pressure. So at 14 you can see the driving pressure is again dropping to 18. The compliance is actually slightly improving. The plateau pressure is dipping. Now you are at a 14 PEEP. The same thing we are repeating. This is in the volume control mode. Last time what we did, the same thing. Now again I am dropping the PEEP to 12. I am putting it in inspiratory hold. See the plateau pressure. Now it is again dipping. Driving pressure is reaching at the target. Now it is at 15. The compliance is improving. So now this driving pressure is at an acceptable level. Plateau is also at an acceptable level. Compliance is also improving. But we will see if I drop the PEEP again, whether the compliance is going to improve. I am again dropping the PEEP to 10. Keeping the, this is volume control 350 ml. Sorry for this mistake. Volume control 350 ml. So here you can see in the inspiratory hold, I am getting a plateau of almost same. But again you can see the compliance is decreasing and the driving pressure is increasing. That means here this is the ideal PEEP for the patient. So now again a volume control mode with a decremental PEEP, a tidal volume of 6 ml per kg. This is how you titrate for the PEEP. Now you see the next patient. Like I am having a patient, I am like an ARDS patient. I am just ventilating the patient. Patient is extremely hypoxic. That is why after intubation, I put the patient on FiO2 100%, tidal volume of 400, slightly high PEEP 7. Then I measured the inspiratory hold. So I am getting like a plateau pressure of 36. Driving pressure is very high. Compliance is 25. And IA ratio I kept it 1.2 and respiratory rate is 18. So I have already told, if you are going for an ABG, you have to always mention what is the FiO2, what is the PEEP, what is the ventilatory tidal volume and respiratory rate. So, or you can write the minute ventilation. Here the minute ventilation will be 400 into 18. That will be the minute ventilation. Tidal volume times respiratory rate. This will have to take it as 0.4 into 18. Okay. So I did a monitoring. So the monitoring now showing SpO2 of 92%. And my ABG is showing 7.3 pH, PO2 of 80, PCO2 of 38. Are you happy with this thing? Are you happy? You are happy having a saturation of 92. Last time itself we have discussed, we have to look at PF ratio. So the PF ratio here is, you are having a 100% saturation and so the PaO2 is 80. So 80 by 1. So you are having a PF ratio of 80 where you are in a severe ARDS group. And now you are in a high FiO2 in a toxic limit. So somehow you have to reduce the FiO2. So what we can do to reduce the FiO2? Again, we will have to open up more airways. So what can I do? Like I have again, now the plateau pressure, my aim is to reduce the driving pressure and reduce the plateau pressure. So obviously I will have to reduce the tidal volume. And as the saturation is slightly high, I am slightly reducing the FiO2. PEEP from 7 I am increasing to 10. Now with the inspiratory hold, my plateau pressures are dipping. driving pressures are dipping, compliance is not having a much change. And to improve the oxygenation in an ARDS, you have to give always more inspiratory time. So from 1:2, I made it to 1:1.5. And as I am reducing the respiratory rate to keep the minute ventilation and to keep the CO2 keep the CO2 within the almost normal limit, I have to increase the respiratory rate also. So I increase the respiratory rate. Okay. Now see, my SpO2 is slightly better as I am increasing the PEEP. At 80%, I am getting 94%. The pH, even though the PCO2 is 54, but my pH is maintained, I am not worried about that. And the PF ratio also, like you can see, the PaO2 by FiO2 will be somewhere around 82 by 0.8 will be more than 100. It is improving. So now again I will see, like I have to see, I still am at 80%. So I have to still improve the oxygenation. So now I have increased the PEEP to 12, and obviously as the saturation was improving, I have reduced the FiO2 to the target level of 60%. Now with an inspiratory hold, I have measured the plateau pressure. It is 15. The driving pressure is 15, and the compliance is also improving. Now I am in a target driving pressure. What other change I can make? Like I can make an IE ratio of 1:1, and I can slightly increase the respiratory rate if required if the pH is dropping. Here actually the pH was not dropping. So the pH is this with this pH I don't have to change, but there was another ABG. So where I was it was showing a dip in the pH. That is why I've increased the rate. So with 30 rate now I'm able to maintain a pH of 7.2. But you can see the PCO2 is still at 62. So friends, please keep in mind, you don't have to look at PCO2 and increase the respiratory rate or tidal volume. You can accept this CO2, that is the permissive hypercapnia, which we have already discussed. You just look at the pH and try to keep it more than 7.15 to 7.2. And now you have increased the PEEP to 12. Still, and again IE ratio you have to keep, and in a severe hypoxemia 1:1, respiratory rate you can go up to 35 to maintain the pH. So now again I am increasing the PEEP. I don't know whether this PEEP is enough. So this is called the incremental titration. Last time we were doing the decremental. So now after ventilating I am slightly increasing. So from 12 I have increased the PEEP to 14. So the plateau pressures are going high. The driving pressures are also going high. The compliance is not. The compliance is also dipping. So this means the patient does not require 14 PEEP. The 12 PEEP is having a better recruitment. Okay. This is how you do an incremental titration of PEEP. This is like after an intubation of an ARDS patient, how I have changed the PEEP and how I have monitored the driving pressure and compliance. What other changes in IE ratio I made, how I changed the respiratory rate for a target pH. So this is how we change the settings. Here we don't have to worry, because as the compliance start dipping, you don't have to further increase and see it is like this is again the compliance is again dipping. You don't have to worry. But here you can see if you are again increasing, that will further reduce the plateau, further reduce the compliance. Okay. So once you see that the compliance is dipping, you have to stop at that point and come back to the previous value. Don't have to again recruit more and see whether it is improving. This is how you do the incremental PEEP titration.